Hi, everybody. This is Dr. Day. Welcome back for week 6 of study tips for exam 2 on common eye problems. The topical list should be looking very familiar to you, and I hope that you've started to fill out your table for the diseases or the problems that'll be covered on this exam. Fitzgerald Amplify Audio Video, I found it to be very in-depth. And a lot of it was more from the emergency room nurse practitioner role with the advanced assessments and examinations. The first 6 slides were devoted more towards advanced and specialized physical examinations. And these are interesting and include a lot on anatomy, physiology, and pathophysiology. And it's discussed in these slides, and it can increase your understanding of other problems. And that I found that helpful. Slides 7, 8, 9, 10 through 15 address more of the problems that are covered on this exam. There's also covered within her information some information on periorbital or preorbital and orbital cellulitis, which is really important for nurse practitioners to know. And also there's some stuff on corneal abrasion and papilledema and floaters, which is good to know also. I don't see that that is covered on this test, but I think it's worth your while to listen to that. And I'm sure you did as part of your assignment. Blepharitis is a common ocular disease affecting males and females equally, and it often coexists with other ocular disease, including dry eye syndrome, conjunctivitis, and keratitis. Seborrheic blepharitis tends to affect patients with rosacea, psoriasis, seborrhea, eczema, and allergies, and can be seen in those with trisomy 21. Poor hygiene is implicated, as well as poor nutritional status and immunosuppression. Exposure to chemical or environmental irritants, as well as the use of eye makeup and contact lenses, may also contribute to the development of this disorder. Staphylococcal blepharitis is more common in younger individuals and is most often caused by Staphylococcus aureus. Posterior blepharitis often is synonymous with Mebonitis. Blepharitis may present with complaints of eye itching, burning, tearing, redness, and foreign body sensation. The presentation can be in unilateral or bilateral, and the symptoms are typically worse in the morning. As far as what you see, the lid margins you can see in this picture are typically a little swollen edematous, erythematous, and you can see with a magnifying glass or a Woods lamp scaling, erythema, and crusting. Anterior blepharitis may present with scale fragments along the lid margins that are easily removed, and the scales may actually encircle the base of the eyelash. With staphylococcal blepharitis, there may be pustules at the base of the hair follicles that may crust and bleed. The lashes can become thin and break easily and cause loss of eyelash. You should palpate the eyelid and lid margins for masses. General pressure on the eyelids may express white sebaceous discharge from the meibomian glands at the eyelid margin, indicating that there's meibomian gland dysfunction. As with any eye problem, it's vital to evaluate visual acuity in both eyes. And in the case of unilateral disorder, in cases just in one eye, visual acuity should be assessed in both the affected eye and the unaffected eye. Any alteration of visual acuity may indicate a potentially serious underlying problem that warrants further investigation. Eyelid and conjunctival cultures are not typically necessary for simple blepharitis, but they may be warranted if the diagnosis is in doubt or the condition is worsening. In your textbook in box 19.1, there's the comparisons of the different types of blepharitis be sure and just read this over and kind of familiarize yourself with those treatments. And please note that eyelid cleaning and compresses are for both seborrheic blepharitis and posterior blepharitis. And for a staphylococcal and severe blepharitis, antibiotic drops or oral tablets are indicated. There's some good information in our text about patient education, and patients should be encouraged to wash their hands, clean towels, prevent any kind of bacteria transfer or viruses to other people. They should avoid environmental irritants, use hypoallergenic soap and makeup, and use care when using contact lenses. And this is often a chronic and recurrent problem, and it doesn't it can completely resolve, but it takes a lot of self-care and treatment. Long-term eyelid hygiene is really the most important thing. It kind of keeps those glands all cleared away. And there are actually pads that you can get for it. They recommend baby shampoo, warm water, eye compresses, and then eye makeup. You know, when it's exacerbated, eye makeup should be avoided. And I know that's hard for some people, but when you get this problem, you'll be glad to. Our patients are usually glad to not wear eye makeup, even though it's kind of unsightly. So there's more information in the textbook about this. A cataract is an opacity of the lens of the eye. I'm sure most of you all have seen this. They may or may not be associated with visual impairment or any kind of functional consequences, and they may form in one or both eyes. Sometimes they develop in one eye only because of an eye injury, a previous eye surgery, a medical condition that affects only one eye. But in some cases, it's just genetics or random chance may play a role. While cataracts are age-related and eventually develop in both eyes, it's not unusual for one eye to develop a cataract earlier than the other. Regular eye exams are important to monitor, and when it's developing more slowly in one eye than the other, their vision is more slowly affected. They don't notice it so much. Of course, these develop slowly, and they usually get into ophthalmology to monitor these when they become apparent. Conjunctivitis is covered quite extensively in Fitzgerald Amplified, and I recommend that you review those slides 13 through 15 again with the audio. Again, and also your textbook is pretty detailed on the various types of conjunctivitis, the differences in clinical presentation and symptoms, and also the differences in management. Conjunctivitis is an inflammation of the conjunctiva covering the sclera of the eye. The conjunctiva protects the eye against foreign materials and microorganisms, but it can become infiltrated by pathogens under certain circumstances. Although most conjunctivitis is self-limiting, some types may lead to permanent vision impairment if not promptly diagnosed and treated. The three main etiologies of conjunctivitis are viral, bacterial, and allergic. And it's important for you as a clinician to be able to distinguish between these different types of conjunctivitis. So you'll need to be able to describe the differences in the definition, etiology, population at risk, clinical presentation of the various types of conjunctivitis. What are the key features that differentiate these types of conjunctivitis? What are the differences in pharmacological and non-pharmacological management for the conjunctivitis types? When should the nurse practitioner in primary care refer for ophthalmological management? And so sometimes you can send to an optometrist. They're easy to get into. They can often walk in, but sometimes they need, an MD, an ophthalmology consult. Be sure to review the chart in your text. It's chart number 19.1. And there's more to this table. So be sure and also review the viral conjunctivitis portion of the table and know some medications that are commonly used to treat viral conjunctivitis. So with allergic conjunctivitis, you can see that there's some over-the-counter medications that you can recommend to patients, and mast cell stabilizers, things like that. NSAIDs is prescription. So you can look at those. Bacterial conjunctivitis, first-line therapy, or various numbers of eye drops, and they're usually used to treat, Staphylococcus is a gram positive, and so you'll see a lot of those antibiotics that treat gram positive. So just be sure and have a general knowledge of what you're going to use and recommend to patients and prescribe to patients should you diagnose one or more of these types of conjunctivitis. So here's another graphic on treatment of conjunctivitis, and I thought this was cute. It's sort of cartoonish and maybe more at the patient level, but education is a lot of what you're going to do with conjunctivitis, because anytime somebody sees their eye, they always think, oh, I have pink eye, I need an antibiotic, I can't go to school. And in pediatrics, in your pediatrics course, I'm sure you'll get more into, when they can go back to school and all that. So general measures, artificial tears, stop wearing contact lenses, cold or warm compresses, and then for viral conjunctivitis, self-resolving antiviral medications like we talked about in the previous slide. Those are important. Bacterial conjunctivitis, severe cases require antibiotic eye drops or ointment, and mild cases can usually improve without antibiotics. Sometimes the antibiotics are going to cause more problems for you because they might have a reaction to them. Their eye turns red and they get more problems, so you don't know what's what. So if you don't have to prescribe antibiotics, I wouldn't. And then allergic conjunctivitis, we saw that on the chart. There's over-the-counter allergy and prescription eye drops. Either they might be antihistamines, NSAIDs, steroids, things like that, and remove allergen, if there's something specifically that they're being exposed to. So I just thought this was kind of a cute chart. Dry eye syndrome is a big problem, especially in older people. I took this little lifespan geriatric considerations from your book. Dry eye syndrome is a multifactorial disease of the ocular surface secondary to tear film abnormalities. In a healthy eye, lubricating secretions or tears, basal tears, continuously bathe the cornea of the eye surface. So dry eye commonly affects both eyes and often presents with eye irritation, burning, tearing, stinging, and blurry vision that are worse at the end of the day, maybe when the eyes are tired. Symptoms may be exacerbated by dry environments, wind, prolonged staring at computer screens, reading, watching television. A few of you might be feeling that way, which are associated with, with a decreased blink rate. So they're holding their eyes open for too long. The eyes can feel hot, irritated, gritty, and may become reddened. And the discomfort experience can be out of proportion to clinical findings. So people will, feel really uncomfortable, but you may not be seeing much. The triad presentation of burning, itching, and a foreign body sensation in the eye is characteristic of dry eye syndrome. This symptom is frequently associated with the diagnosis of Sjogren's syndrome, which is a systemic disorder affecting the function of all secretory glands. In the vast majority of patients, dry eye syndrome is not vision threatening. However, untreated dry eye and severe dry eye syndrome may result in inflammation, erosion, and eventual keratinization of the cornea or conjunctiva, which may permanently affect their vision. So it's not to be taken lightly, but you can help them pretty quickly with wetting those eyes and kind of keeping them, treating the dry eye. So looking at the opposite of dry eyes, you have excessive tearing or epiphora. And excessive dry eyes may actually cause excessive tearing, and it's called reflexive, or it's kind of reactive to the dry eyes. So it's the present epiphora is the presence of a watering eye caused by increased lacrimation or impaired tear flow. So good ocular surface lubrication is a sign of a healthy eye. However, an eye with uncontrolled tearing signals a malfunction with a variety of causes. And you can see this list here. Some of them are allergies, dry eyes, environmental irritant. So it doesn't have to be an environmental allergy. It can just be an irritant like walking into a chemical, smoke, things like that. Eye strain, inflammation, some various medications, pain, trauma. So a good history history on this patient, including medications, is important. Impaired tear outflow is another one of the causes, and those are categorized into eyelid abnormalities, nasolacrimal duct obstruction. It's abbreviated NLDO, and you'll talk about that a lot in pediatrics. Ectropion, entropion, and Bell's palsy. For management, treatment of excessive tearing involves targeting an underlying cause. So there's no medication just for tearing. You have to treat the underlying cause. So treatment of tearing secondary to trauma or infection includes maybe topical antibiotics for treatment. Steroid eye drops, anesthetic drops should not be used in these cases because they may disrupt healing and increase the risk of infection. If a foreign body is visualized on physical examination, it should be removed by saline irrigation. And if you can't get it out, then you can refer them. And you can also try using a moist cotton swab. Eye rest is important, but we do not patch the eye. Treatment of allergic causes of excessive tearing, like allergic conjunctivitis, treat that. And you can use cold compresses for comfort and relief of itch, topical antihistamines, topical NSAIDs, mast cell stabilizers, and systemic antihistamines. But remember, systemic antihistamines are going to further dry out those glands. And occasionally a consultation with an allergy specialist if it's true allergic cause for excessive tearing. You can tell by these pictures that eye floaters are hard to describe, and they're hard to draw a picture of. Sometimes they can be little spots, sometimes they can be like little fiber looking things, sometimes it can just be white shadows. And they usually happen because of normal changes to the eyes during aging. Tiny strands of vitreous stick together and cast shadows on the retina, and those appear as floaters. But sometimes they can have more serious causes, including eye infections, injuries, uveitis, bleeding in the eye, and the most serious would be retinal detachment. And sometimes new floaters can be a sign of a retinal tear or retinal detachment. And when the retina gets torn or pulled from its normal position at the back of the eye, they can have some floaters appear. And sometimes they're flashes of light. Sometimes they're like a dark curtain or shadow in the central vision. And retinal tears are a medical emergency. So if you have a patient that is not just your typical floater that kind of come and go, but more serious sounding, then send them out for an evaluation, a physical examination. Glaucoma results from increased pressure inside the eye, and this can damage the optic nerve and lead to vision loss if it's not treated. Early detection through regular exams is essential, and treatments include medications or surgery to lower eye pressure. So there's two different types. You have the open angle glaucoma and the angle closure glaucoma, and there's differences in presentation. And there's a little diagram here to kind of show the differences in that. And also, you can find in Fitzgerald Amplify that this is pretty well explained starting on slide 7. Even though it might be kind of high level, it's good to review that again. Open angle glaucoma is by far the most common type and is characterized by a chronic progressive disorder, but it does cause optic nerve damage and associated vision field loss. It typically has good prognosis if it's recognized early and treated, but angle closure glaucoma, on the other hand, may have subacute and chronic components, but it's most often associated with acute episodes of significant eye pain, redness, and acute visual loss, which if untreated may rapidly lead to permanent blindness. So when you're looking at a red eye, always have closed angle closure glaucoma on your radar. Don't just assume it's a conjunctivitis, because you could be looking at something that's an ocular emergency. Generally, patients with open angle glaucoma are asymptomatic until they have optic nerve damage. But in acute angle closure glaucoma, it's more rapid. It could be unilateral pain and pressure, blurred vision, halos around the eyes, and photophobia, loss of peripheral vision, and subsequent loss of central vision. So this is not good. And they may get a headache, they may get nausea and vomiting. So there is a chronic angle closure glaucoma, which is a little more insidious, and it may be more vague. In the primary care setting, the physical examination, and most patients with chronic glaucoma you probably wouldn't see anything. You shouldn't see, visual acuity affected that much. A Marcus Gunn pupil, which is an afferent pupillary defect, and I think that Fitzgerald talks about this pretty good, may be present, particularly if one optic nerve has more severe damage than the other. So you want to be sure and know the findings on physical examination for the different types of glaucoma. What might that pupil look like? And the pupil of the affected eye may be mid-dilated and non-reactive. The fundoscopic examination may show a pale optic disc with excavated cupping and a shallow anterior chamber. So these are all kind of words that you might see on your boards and on exams within your course. There may be an increased cup-disc ratio and asymmetry, and that means that when you examine the eye, you have to be able to see the back of the eye in order to understand all this and to be able to identify it. For glaucoma management, these medications are prescribed by specialty care, either optometry or ophthalmology. Know the classes of medications that treat glaucoma. Understand that these medications can interact with other medications that you prescribe, such as beta blockers. For Hordeolum, Chalazion, be sure and know the differences in evaluation and management between these two problems. There may be pictures that you need to look at, and you can see in these pictures that the Hordeolum is more right on the border of the lower lid, and it looks like pus, looks a little pimpleish, whereas the Chalazion is a lump, and it can be on the upper or lower, and it's more of a lump. And know when to refer to ophthalmology or an optometrist. And your main reference is your textbook. But I'm going to provide a video link. You can see it below this video in YouTube. And there's a good review course on YouTube that an outside link for audio-visual explanation, and she does a really good job talking about, the risk factors and the clinical presentation, diagnosis, and management. So I'm not going to try to recreate that one, but I think she does a good job. So look at the link below. So you can test yourself here. Gabriel comes into the office today with a painful right eyelid. It started 2 days ago and now is really bothering him. Inspection shows the following picture. What is your diagnosis? A. Chalazion. B. Hordeolum. C. Blepharitis. D. Meibomian cyst. So this one should be pretty easy. What did you think? I was thinking also Hordeolum because they can they both present as a gradually enlarging localized nodule, but a hordeolum is usually painful, whereas a chalazion does not normally cause pain, although I personally have had one and it was big enough to cause pain. But typically after 2 days you're not going to have pain, you're just going to have a lump with chalazion. But and also in that picture you can kind of see that little yellow sort of spot on it, which is another clue. So let's test our knowledge again. What therapy would be most appropriate for this same patient? A, drainage of the cyst. B, tobramycin 3% and good eyelid hygiene. C, warm moist compresses and massage. D, levofloxacin with warm compresses. What do you think? Hordeola are usually self-limited, spontaneously improving in 1 to 2 weeks with conservative treatment alone. Lesions may be treated with frequent application of warm, moist compresses with light massage over the lesion to facilitate drainage. Daily lid hygiene with lid scrubs can also be beneficial. Topical antibiotics are generally not effective or indicated unless an accompanying infection is present. Systemic antibiotics are generally indicated only in rare cases of secondary eyelid cellulitis. That's a different problem, right? Any patient for whom conservative treatment fails or develops a secondary infections like conjunctivitis or cellulitis should be referred to an ophthalmologist. Large persistent lesions may require incision and drainage by an ophthalmologist. Cultures are not indicated for isolated, uncomplicated cases of hordeolum. Diabetic retinopathy is a non-inflammatory disorder of the retina that develops in patients with diabetes. It's typically divided into non-proliferative diabetic retinopathy and proliferative diabetic retinopathy. The initial evaluation for a patient with diabetes should include a referral to an ophthalmologist for a comprehensive eye evaluation with particular attention to the diabetic eye exam or the retina. Your patients should normally they're on a schedule of once a year having this exam where the back of their eye is examined after eye dilation. Diabetes is a fast-growing epidemic, of course. 1/3 of patients with diabetes will develop some sort of diabetic retinopathy, and that accounts for 10% of new cases of blindness each year. Diabetic retinopathy is the leading cause of blindness among Americans aged 20 to 64 years. But the leading cause of blindness in the world is refractory issues such as cataracts. You can see in the picture of the retina that there are red spots, and those are the hemorrhages. And these were often described as cotton wool spots on the retina because they're like little puffy little spots. The first goal of patients with risk for microvascular complications from diabetes is prevention. So tight sugar controls, you want to set a goal for your sugars and for your glucose control. And so the American Diabetes Association says that you should control the A1C at less than 7% to prevent diabetic retinopathy. Patients with hypertension and diabetes should strive to maintain a normal blood pressure, and you studied those normals for the last test as far as blood pressure, and many patients have both disorders, so really controlling that BP and the sugars is going to help keep your patient from blindness, keep them from going blind. So laser photocoagulation is recommended. Of course, this is done through specialty care, and that's pretty much what they do. There are some other specialty things that they can do and to treat this, but the main thing on the primary care side is to prevent it from occurring through blood pressure and blood sugar control. Age-related macular degeneration is a disorder that affects the macula, the central part of the retina, causing central vision loss. It's most common in older adults, and while there's no cure, treatments can slow progression and help manage symptoms. It's most common in older adults, like I said, and they're increasing the risk of vision impairment with age. So AMD, you hear about this on the television, you hear ads for treatments and things like that. There's wet macular degeneration and dry macular degeneration. So it's estimated that dry AMD accounts for 85 to 90% of all cases in the United States. Occasionally, those new blood vessels will develop into the retina. But it's only occasional. But the other condition is known as exudative or wet AMD, and it typically presents with a sudden decrease in vision that requires immediate referral to an ophthalmologist. Wet AMD accounts for approximately 10 to 15% of all cases in Northern America, and there can be a progression from dry to wet macular degeneration. So it's our task to determine whether the problem is acute and requires referral for immediate treatment or is more routine. Establishing whether the onset of the visual impairment is acute or gradual will assist you in making that call. Likewise, the severity of the vision loss is also important. Severe or sudden vision loss requires immediate referral. Although there's no proven cures for AMD, there's various studies that have shown a positive association between nutrient intake and decreased risk of AMD. So reducing the risk through nutrition was supported by evidence. And so there was vitamin C, E, beta carotene, zinc. You'll see those eye vitamins or supplements, and that's what's in them there to prevent this. So you can see here that the risk factors for age-related macular degeneration. Treatment for age-related macular degeneration. This is done by an ophthalmologist, but just so you know, some of the treatments that you may see are the anti-VEGF injections. They use drugs like Avastatin, Lucentis, Eylea, and Vabysmo into the eye to block the growth of new blood vessels and leakage, which can preserve or even improve the vision. There is other drugs in here that you can see that they use to inject, but the main thing is the class of the medications, and you can see those in their vascular endothelial growth hormone, growth factor receptor fusion protein, anti-VEGF monoclonal antibodies, and nucleic acid VEGF inhibitors. For dry AMD, the nutritional supplements have been shown to help. The age-related eye disease study, AREDS, shows that a combination of vitamins and minerals may slow the progression of dry AMD. I'm sure you've all heard the commercials about that. So late stage dry AMD, they sometimes need to have the also the treatments. So you can refer these to ophthalmology. This chart is from your textbook. It just shows different differentials for causes of impaired vision, and you can kind of read that over to get kind of the global picture. Retinal detachments are a severe ocular condition that can lead to permanent vision loss. When the neurosensory retina detaches from the retinal pigmentation epithelium and the choroid, it loses its oxygen and nutrient supply. You can see that in the diagram shown. And when this happens, it leads to death of tissue. Retinal detachment can be classified as several different ways but these patients may present with history of many new onset floaters. So that's one of those, we mentioned that earlier, that if they have floaters, it can be a sign of this. They may also have significant photopsia, which are flashes of light in their vision. And they often present with progressive or fixed field vision loss, typically starting in the periphery and moving centrally. Other essential aspects of the history include timing of the onset of the symptoms. If the patient has the same level of the same visual loss symptoms in the same eye or two eyes, with central visual acuity is affected. And if they have prior surgery or previous trauma, these are all kind of risk factors that you would find in the history. So be sure and get a complete review of systems and past medical history, and take note of any previous vision problem, LASIK, things like that. And the essential aspects of the physical exam, including the best corrected visual acuity in each eye, checking the pupillary reaction of each eye, and relative afferent pupillary defect, and confrontational visible field testing. And checking the intraocular pressure is helpful, and we refer to get that done. Most clinics can't do that. You may be in one that does. So these are referrals. If you suspect this, go ahead and send them out. An optometrist can see them right away. If you have connection with an ophthalmologist, that's always better if they can get them in. If they can't, then send them, because an optometrist will often have connection to an ophthalmologist. So just getting them in to have those, the pressures and a good dilated exam will help. You'll hear in the audio video recordings when they're talking about vision problems and doing an evaluation, and they'll talk about a slit lamp. Well, this is a picture of a slit lamp. Have you seen them in your primary care clinics that you've been at for your practicum? You may see them in urgent care or in the emergency department, but I haven't seen them in a clinic. I see two problems that are not included on this exam, and I'm assuming they're included in other places in your program, but they're important for you to know in primary care. They're orbital cellulitis and peri or pre-orbital cellulitis. Orbital cellulitis is an acute urgent condition. You can see a picture of it. It involves cellulitis that's moved into the orbit, and it's an emergency. So you want to send them out very quickly to the emergency room and get them taken care of. They're probably going to need IV antibiotics and treatment, and they need specialty care. But you don't want to wait for an appointment. You want to send them to the emergency room. There is a video link here. And in that video, it's a real good explanation, but it also has chapter marks in the video, so you can go right to the chapter on this and just familiarize yourself with it, because it, as a primary care provider, you may see this. You will definitely see periorbital or preorbital cellulitis. This is cellulitis in the skin that has not yet gotten into the eye, into the orbit. And generally this is outpatient management, but you want to treat this before it gets into the orbital cellulitis, which, could be loss of vision, loss of the eye. Thank you for listening to this video, and I hope that it helps you prepare for your exam. Some other study tips I could advise is to seek out audio-video resources aimed at family practice board exam prep. This can be either medical or nurse practitioner. I find it helpful when searching for free videos on YouTube to type in medical family practice board reviews. And then it'll pop up some of these professional organizations that do board reviews. There's also nurse practitioner board review professional reviewers who sell their whole board review in audio and video format that are available online. And that if you're getting ready for your boards, it might not be a bad time to go ahead and start doing that, because viewing those types of resources will also help you prepare for course exam, program exams, and also it'll help you in clinical. Complete the study guide table. And strangely enough, studies have shown that learning occurs during the process of writing by hand. And I know this has kind of gone out by the wayside. People like to copy and paste and then read it. And that's fine too, if that's the way you learn. But studies have shown that kinetic movements along with tactile stimulation of the act of writing has been shown to help information register in the brain. So consider handwriting the table. And of course, read your textbook chapters. Everything that you need to pass this course is within your chapters and other resources that are provided within the course and Fitzgerald. So be sure, and reading is probably the best way. And also look for additional resources from audio, video, write, those type of things, help you to retain information and for it to make sense. And another tip is to don't cram. Always allow yourself to sleep before you take a test, because you can put all this information in your brain, and while you're sleeping, it will reorganize and it will be, it'll make more sense the next day. I know that the old saying, let's sleep on it, there's a reason why that came up. So don't hesitate to reach out for questions or concerns, and I'm here to help. Thank you. Bye.